A very good evening to all. Welcome, dear PGs, to the 6th module of our PG Clinical Exam Crash Course series. So we have been doing it for some time, sir. For source information, I'm just telling the 6th module, Retina. And today's topic is all about Retina. And let's welcome Dr. Vignesh, Senior Consultant Associate Professor from Aravind Eye Hospital, Madurai. He's a PG mentor, a great teacher. Warm welcome from all of us.
Thank you. Thank you.
So we'll be discussing all about the clinical aspects concerned with retina cases from a PG level and the examination point of view. As already I mentioned in previous modules also, please avail, this is an interactive session, please avail to the maximum. It's a golden opportunity to have Dr. Vignesh for you. So please avail it and utilize it properly. Let me also welcome our own member, Treasurer KOS, Dr. Mihir Shah, as a Senior Consultant, Vascular Eye Care Hospital, and also Dahlia, Scientific Committee member. She is a Senior Consultant at Srikanth Eye Hospital. Welcome, Dr. Mihir, and welcome, Dr. Dahlia, and over to Dr. Mihir. Thank you all.
So, good evening all, and welcome to this 6th module of our crash course series. So, I would like you all to introduce Dr. Vignesh. Dr. Vignesh, first of all, he is a colleague of mine during my Aravind days. We go long back. So, and the reason we have got him here is that because he's a mentor to the PGs at Aravind, and he's more experienced in conducting classes and preparing the PGs for the exams, and also to prepare them to present papers and also publications. So I would like to give a brief intro. Dr. Vignesh is a Senior Consultant and Associate Professor, Department of Vitreous Retina at Aravind Eye Hospital, Madurai. He did his MS in Ophthalmology at Aravind Eye Hospital, followed by his fellowship in vitreoretinal surgery from the same institute. He was a Senior Research Fellow at Queen's University, Belfast. He also had the opportunity to visit and observe some very prestigious institutes in the US. He has presented many papers at national and international conferences. He has 6 publications in international journals, and his areas of interest are macular diseases and pachychoroid diseases. And in stark contrast to all his achievements, he's really down-to-earth person and more of a friend to his postgraduates than a teacher. So you please feel free to interact with him, to ask him your doubts, and whatever is being asked, please answer. That's the only way you can learn, and you make mistakes and you learn, and that's how you come forward. So I won't waste much time. Over to Dr. Vignesh. You can start your session. Yeah.
Thank you. So good evening all. First of all, I would like to thank Dr. Mihir Shah and the Kozhikode Ophthalmic Society, Dr. Videsh Madam, for the invitation. So before starting, so all the PGs, I want to tell that. So it's only for discussion. We're doing it. So you need to you can answer the questions and what I'm presenting here, and let it be more interactive so that we can discuss, and then you need to answer the questions and then we can discuss. Yeah. So I'll start the presentation. So I have basically put some few ASCII questions around 16 cases, and then we'll have some 2 short case presentation, and then followed by frequently asked questions in retina. So I want the PGs to answer the questions. So I'll just first present the first slide. Is ASCII. Number 1, a 45-year-old female patient with history of diabetes mellitus for past 7 years. Presented with complaints of defective vision in left eye for past 6 months. So first question is, what is the cause of defective vision in this case? So PGs can answer.
Macular edema, sir.
Yes, good. Macular edema. So what are the lesions seen in this fundus?
Adexude.
Yeah. So hard exudates, then good.
Here, dot and blood hemorrhage.
Yes, dot and blood hemorrhages.
Then,
Yeah.
microaneurysms.
Yes. So what is the diagnosis in this case? In this eye, in the left eye?
Severe NPDR.
Yeah, good. Severe NPDR.
Severe NPDR with macular.
Okay, good, nice, good. So how will you treat this case?
IVP.
Yeah.
First, we had to deal with macular edema.
Yes, correct.
So we can give, after taking the OCT, we can do intravitreal anti-VEGF followed
Yes.
by PRP.
Yes. Yeah, we have to investigate further, like we can do on fluorescein and then identify if it is whether it is still a severe NPDR or PDR. And then we can go in for, if it is PDR, we can go in for PRP. If it is even severe NPDR, the patient cannot follow up. We can, if it is very severe and even after repeated injections of anti-VEGF, the edema is again recurrent, then we can go in for PRP in this case. Yeah, good. So we'll go to the next slide. So a 52-year-old male patient with a history of diabetes mellitus and hypertension for past 10 years. So he came for a routine checkup. So can anyone describe the lesions seen here?
Multiple dot and blood hemorrhages at the mid-peripheral area.
Yes, yes. Good.
Hard exudates nasal to the disc.
Yes,
Somehow
good.
nasal.
Yes, then important thing.
Arterial narrowing.
Yes, correct. Good. Because of the hypertensive changes. Yeah, you are right. Another important thing in this which is seen very well.
Venous dilatation.
Yes, that is also correct. Another most important thing.
Neovascularization.
So where is the neovascularization?
Infronasal to the disc.
Infronasal. I'll show you the pointer. Yeah. So this is the neovascularization. Good, good. So what is the diagnosis in this case?
Ocular ischemic syndrome.
Why ocular ischemic?
Because the dot and blood hemorrhages are more of at the mid-periphery.
No, actually, I have put a wide field photo. This is an up close picture, so I have cropped the picture and put this one. So you are seeing hemorrhages throughout only. So you are seeing in the foveal area, macular area, around the arcade. So it is seen throughout only.
Okay, sir.
Yeah. So what is the diagnosis now? Yeah, ocular ischemic. You have to have a.
Sir, combined retinopathy
Okay. So
with
yeah,
hypertensive retinopathy.
Yeah, so we call it as mixed retinopathy, but here it is universal. So we have to say PDR, proliferative diabetic retinopathy. Yeah, proliferative diabetic retinopathy. So what are the investigations to be done in this case?
Fluorescein angiography.
Macular ischemia.
Yes, good. So yeah, so here it is the clinic because the patient came for a routine checkup, so we didn't have any visual complaints. So just to rule out subclinical edema, so we have to do an OCT, and also the other eye, like if we have not found out the universal, then we have to go for FFA. And yeah, you are another point. A good point is like to rule out vascular ischemia. Right. What are the blood investigations you will do?
The glycemic status has to be assessed. So FPS, PPBS, HbA1c, and the renal status, the serum creatinine and blood urea.
Yeah. Then anything else?
The fasting lipid profile.
Yes, very good. Yes. Then anything else? So you're covered 99%. One test is missing that we have in our like every patient we do it.
Complete blood count.
No. So it's a urine microalbumin. So we know like microalbuminuria, no? So yeah, so you're told correctly. So what we do is fasting blood sugar, HbA1c, lipid profile, blood urea serum creatinine, and urine microalbumin. This is a routine test that is followed at every branch, every hospital branch of Arvind here. So we do this test for every patient of diabetic retinopathy. Lesser the severity, we at least do once, like maybe once in 6 months or 1 year, mild NPDR means. Otherwise, we do all the severe cases at least 3 months once. We insist them to take HbA1c. Okay, so what is the treatment in this case? Yeah, so PRP. So after finding out that there is no nephropathy and all, so usually we do PRP in how many sittings?
3 sittings.
Settings.
3 sittings.
Yeah, 2 to 3 sittings. So if the nephropathy is there, what we should do?
More number of sittings because
Yes.
it
Why we have to do like that?
macular edema, increased chance of macular edema.
Okay, that is one thing. Another thing, any other reason? So actually, so one more test I forgot to mention is hemoglobin. Hemoglobin is very important because even in anemia, there will be severe. Severity is more in the diabetic retinopathy. So in anemic patients, in patients having nephropathy, we usually do PRP in 4 divided sittings, 3 to 4 divided sittings. And even in uncontrolled diabetes, like around HbA1c more than 12, more than even 10 also we have to do like that. So 10 to 15. So what is the maximum HbA1c anybody has seen? How much HbA1c with the maximum?
13.
Yeah, 13?
13, 14 is.
13, okay. So today I saw one patient, his HbA1c was 16.9. 16.9. So he had PDR with vitreous hemorrhage. So even hemoglobin we have to see because if you see compare with the severity of DR with the hemoglobin, more the severity, lesser will be the hemoglobin. So anemia case also we have to do. The main reason I told is nephropathy is if you give heavy burns in nephropathy case or severe anemia case or uncontrolled diabetes case, the chances of developing choroidal detachment is more. Also, exudative macular detachment is more, not just macular edema worsening. So that point you have to note down. Okay, so how to follow up the patient after treatment? So you do PRP and then how do you follow up? How many months? No, after PRP, how do you follow up?
3 months.
Yes, anybody answering?
3 months.
Okay, so first after PRP, no, not 3 months, 2 months actually. So 2 months you have to follow up. So if you are not able to do complete PRP because of vitreous hemorrhage, then you follow up monthly. And after 2 months, still the lesions, the new cells are still active. But if the laser is given adequately, we can follow another 2 months once. But if the laser is inadequate, vitreous hemorrhage is clearing, and those areas needs to be given laser, that areas has to be covered. So once you feel that it is stable, then we slowly increase to 4 months and then 6 months. Then every 6 months, every stable case of PDR post PRP, we have to follow every 6 months once. Okay, so any other doubt you can ask me, otherwise we'll go to the next question. Okay, so I'll go to the next slide. So a 30-year-old female patient presented with complaints of defective vision of 1 month duration. So what is the diagnosis?
Retinal detachment,
Retinal detachment.
or probably rhegmatogenous.
Yes, rhegmatogenous retinal. So what are the described lesions seen here? Like anything is seen? Yeah.
Lattice degeneration can be
Yes,
seen.
very good, very good. Lattice degeneration with retinal detachment. Yeah, so holes are not very clearly seen, but we can see here, like, okay, area of thinning at this small hole here, another hole here. Good. So what are the risk factors for retinal detachment? Rhegmatogenous retinal detachment.
Peripheral retinal degeneration like lattice degeneration, high myopia,
Yeah.
trauma,
Yeah, correct.
Then
Anything else?
systemic disease like
Yeah, systemic disease like?
sticklers,
Yes,
back.
very good. Good.
Then post IOL surgery, if there is any vitreous discharge.
Yes, yes, very good. Anything else?
Marfan syndrome, Ehlers-Danlos syndrome.
Yes, good. Okay, so how will you treat this patient? What is the treatment you have to do here in this retinal detachment?
Pars plana vitrectomy with the laser and along the break.
Okay.
Then internal tamponade can be.
Why not scleral buckle in this case?
Because there is active vitreous traction, so we should do.
So, but the patient is young patient, no? So vitrectomy has its own complication.
Yes.
So yeah, so okay. So all the youngsters nowadays are shifting more into vitrectomy. So actually, see, we have like scleral buckle plus vitrectomy and primary vitrectomy. So like the decision is made like nowadays most of them are doing vitrectomies rather than doing buckle. But actually, who are trained like maybe 20 years back, 15 years back, not like more they'll do for young people, no, better to go for buckle first. So buckle, scleral buckle with subretinal fluid drainage. So the buckle is covering the break very well adequately. This will definitely settle down. But if there is again recurrence, then we can go for vitrectomy. There is two-stage procedure. But as a young patients, in this like it is still not even total RD. It is still macula sparing RD, and the breaks are very well localized. So the first choice will be buckle. In pseudophakic cases, where the breaks are not very clear, in PVR changes, proliferative vitreoretinal changes, or in retinal dialysis, and giant retinal tear, then we have to go for buccal plus vitrectomy. Okay. So, is there any prophylactic treatment to prevent this condition? Could this have been prevented in this case?
To the peripheral lattice.
Lattice degeneration.
Yeah, so lattice degeneration should have been treated before, like the lattice with holes. So, what is the treatment?
Barrage laser.
Very good, very good. Good. So, we'll go to the next case. So, this is a little tough case. A 55-year-old male patient came with complaints of defective vision in left eye for past 6 months. So, what is the diagnosis? So, I'll show you the lesion. This is the lesion we are seeing here. So, what is the diagnosis?
CNVM.
CNVM.
Very good, very good. So, CNVM is easily found out. Okay, so what is that below? What is this image?
OCT.
What is seen here? Yes.
OCT.
OCT. Good, very good. So, what is this lesion?
Subretinal scarring.
No. So you can see something yellow in the fundus photo. So I am showing you something there, correlating there with that OCT. So what is that?
Oh.
So first identify what is there in the fundus photo. The yellowish thing.
Vitelliform.
Yeah. Okay. So what are the further investigations needed in this case? So you have found out the CNVM. So how will you confirm the CNVM?
FFA and ICG.
Very good, very good. FFA and ICG, super. So treatment of the patient? What treatment will give? CNVM is we have identified. So what treatment will give?
Anti-VEGF and PDT.
Yes, very good, very good, very good. So here, this is a case of CNVM post CSCR. So what we are seeing here is subretinal fibrin. Yeah, fibrin or fibrin. Fibrin. Okay. So that is what is seen here. So usually CNVM post CSCR is a rare complication. We see in around 5 to 7% of cases. And some cases where we have treated with heavy laser also can develop CNVM. So, but in this case, we are not seeing any laser marks. So the patient would have had chronic CSCR for a long time, and then he would have developed this CNVM. So this is a post-CSR CNVM. Okay, so anti-VEGF is the treatment, and these cases will have better prognosis than ARMD patients. Usually they will have better prognosis. Okay, so next patient, a 60-year-old female patient presented with complaints of decrease in vision of 1 week duration. This is a known hypertensive and cardiac patient. So what is the diagnosis? This is very simple.
Central
CRV.
with macular edema.
Very good. So she already has 2 risk factors. So what are the other risk factors? What are the risk factors?
Anemia.
Atherosclerosis.
Okay.
Hypercoagulable conditions.
Very good. Very good. Hypercoagulable state. Very good. Next. What about diabetes?
Diabetic.
Yes.
DDR. Hyperlipidemia.
Yes. Yeah. Diabetes mellitus. Then yeah. Somebody else told you. Another.
Hyperlipidemia.
Okay. Very good.
Intraocular factors like raised IOP.
Yes. Very good.
Hypercoagulability.
Yes. What? Any other blood disorder?
Autoimmune conditions.
Hyperhomocysteine.
Yeah. Very good. Very good. Hyperhomocysteine is seen in. You're right. Very good. Right. So hyperhomocysteine is seen more commonly in smokers. Okay. Then next. Okay. Then what are the relevant investigations you will do in this case? So already one investigation is done. Anything else you need to do? You first tell about systemic investigations, then tell about ocular investigations. So you already told the risk factors. So it is very easy to order the test for the systemic investigations.
CBC, ESR.
Okay.
Homocysteine levels.
Yes, very good.
PAPTT and coagulation status of the patient.
Okay. So in younger patients, you need to have the entire CBC, coagulation profile, below 50 years, no other risk factors, you have to do all the tests. In older patients, like they already have some disease like diabetes, hypertension, so we have to do the routine test for other like a diabetic profile, lipid profile, cardiac profile. Okay, so what are the other tests you will do? Like any scans, systemic.
Carotid Doppler.
Carotid Doppler.
Yes, very good. Carotid Doppler and echocardiogram. Both you have to do. Okay. So how will you treat this patient? So what is the treatment now? Yeah, you are already treatment for most of the medical retinal diseases are same. So you have been telling from first slide. Yes.
Anti-VEGF.
For macular edema.
Yes. So any yes, after that, anything else?
Treatment of constitutive factor.
Follow up, look for NVI and neovascularization.
Yes. Very good, very good. So what are the complications if left untreated?
Neovascular glaucoma.
Yes, very good. So neovascular glaucoma. So once neovascular glaucoma has set in, then what's the treatment?
Aggressive PRP.
Yes. Along with? Yeah, aggressive PRP is correct. Along with anti-VEGF, we have to give aggressive.
Bony photocoagulation.
No, along with anti-VEGFs. So you have to combine anti-VEGF along with photocoagulation. Good. So we'll go to the next. This is a simple case. 45-year-old male patient with complaints of defective vision in the right eye of 2 days duration. He is a known hypertensive for past 5 years. What is the diagnosis?
ITBRVO.
Branch retinal vein occlusion.
Yeah, ITBRVO, full diagnosis. ITBRVO with
Macular edema.
Very good. So anything, how is the disc?
Cup, increased cup.
Cupping is more, no?
Yes,
Yes.
sir.
Yes.
Okay. So we have to investigate further for glaucoma as well. Okay. So from the retina point of view, what are the investigations to be done in this patient?
OCT, fundus angina.
Okay. So if you suspect new vessels, then you have to do, along with OCT, you have to do FFA as well.
FFA.
Yeah. The only hemorrhages are there. If there are no new vessels suspected, then no need of doing FFA. We have to treat only with anti-VEGFs. Okay. That I already told the answer also. So how to treat this patient?
Anti-VEGF.
Anti-VEGF. Okay. So what is the prognosis in this patient? So what are the factors that determine the prognosis? So before going for anti-VEGF, we have to do what can be done for systemic diseases. See, the patient is hypertensive. Okay. So first we have to go first look for BP. The BP is very high, and the patient is having macular edema, but the vision is good. So what we can do is first treat the hypertension and have a very close follow-up. Within 2 weeks, once the pressure is controlled, again do an OCT and check for macular edema. If the macular edema is still persistent, then we can go for anti-VEGF. The way I'm telling is this from my personal experience I'm telling. So one patient presented like this only. I had seen that BP was very high, around 190/120. And the patient had macular edema. But interestingly, the macular edema, the vision was only 6/9 partial, something like that, BCVA. So I didn't do anything. First I did was, I investigated thoroughly, but no other finding except BP. So I asked the physician to give the treatment for hypertension. Once the hypertension came down, the macular edema came down in 15 days. So first we have to do systemically, you have to treat, make sure that the systemic problems are controlled well, and then give anti-VEGF, because even anti-VEGF you cannot give in a uncontrolled hypertension patient. Okay. Fine. How to follow up the patient after treatment?
3 monthly follow-up.
No, this needs every month follow-up. Every month you have to follow up for, there can be recurrence of edema. So you have to follow up the patient every month. So once you treat the systemic diseases, then give anti-VEGF and then follow up the patient every month. Once the patient has stabilized, then we have to prolong the follow-up. Maybe like once we see like the edema is not coming, like after at least 3 months of follow-up, then we can make it 2 months and slowly increase the duration. Fine. We'll go to the next case. Related case, but little different. A 30-year-old female patient presented with complaints of defective vision in left eye for past 6 months. So what is the diagnosis in this case?
Supratemporal.
Right. So what is the cause in this case?
Vasculitis.
Vasculitis.
Yes, very good, very good. So vasculitis. So what for the other investigations you will do in this case? So when you know it is a vasculitic PRVO.
Manto.
Yes, good.
Routine investigations with CBC, ESR, ANA.
Very good.
Infective CRP should be checked.
Yes.
Manto to rule out tuberculosis.
Okay, very good. So we usually do TCTC, ESR, Manto, TPHA, or bar BDRL, and also HIV. This is a routine test we do in the UVA clinic. So in addition to that, if you suspect anything autoimmune etiology, so you have to do ANA. So what are the other tests you will do? Like if you suspect autoimmune vasculitis.
Pianga.
Okay, very good, nice. So how will you treat this patient? Anything different from the routine PRVO? What will you do in this case?
Once infective etiology ruled out, systemic steroids need to be given.
Yes, very good. Then once the inflammation is controlled, and if we suspect any new vessel, we can even do a FFA in this stage. So to rule out any active inflammation, because in FFA there is active inflammation, there will be leakage. Okay, so leakage from those vessels as well as perivascular leakage will be there. Then we have to control your treatment. Your goal is correct. We have to control the systemic inflammation. After 2 weeks, then we found out after 2 weeks of that, controlling the systemic inflammation, we can go ahead with sectoral photocoagulation. If there are NVEs, fine. So another simple case, 61-year-old male patient with sudden loss of vision. He's giving history of hypertension and he's a smoker. What is the diagnosis?
CRA.
CRAO.
What are the risk factors? 2 I have already told. He's having 2 risk factors. Other risk factors?
CAD.
Epidemia.
Treatment surgery.
Okay. There are several causes, no? So a few I have told. Some more.
Valvular heart diseases is a risk factor.
Okay. So any investigations you will do in this patient? What investigations will do?
Coagulation profile.
Carotid
Okay.
Doppler.
Yes, good. So, but before investigations, we need to treat now because it's an emergency. So, what are the treatment you will do? So, once you
Ocular
assess that,
massage.
Ocular massage.
yes, very good.
AC
Massage.
paracentesis.
Yes,
Diamox.
yes,
Diamox.
Diamox. Yes, very good. So these are all to reduce the IOP so that the emboli will get dislodged if you find an emboli. So sometimes miracles do occur, like because it's like we have to treat this CRAO within 90 minutes because the retina will get infarcted beyond 90 minutes. So, but sometimes we have seen cases like recovering even after 6 hours or within 12 hours, we're going to give the ocular massage. Cases improving just with ocular massage alone because like paracentesis is little invasive, so there are risks are involved like endophthalmitis and all those things. So even just with gonium massage, you are going to see the emboli first and do a gonium massage, see that emboli getting dislodged. So to the smaller branches, there are chances that the vision will improve. Okay. So what is the visual prognosis?
Bad prognosis.
It depends upon the timing. So if you're going to do it within 1.5 hours or even within 6 hours, the treatment, the chances of improvement is there. But the patients are presenting after 12 hours or 24 hours, the visual prognosis is usually very poor. Okay. So we'll go to the next case. So what is the diagnosis? So the arrow is already there on the fundus photo. So what is the diagnosis?
Retinal macro.
Aneurysm.
RAM.
Subhymeloid myeloid hemorrhage. Retinal hemorrhage.
Okay. What are the risk factors?
Hypertension. Female.
Hypertensive female. Middle-aged female.
Super. Very good. So what is the investigation you will do? I already put the investigation also.
Fundus fluorescein angiography.
Okay. What are you seeing the fundus fluorescein angiography? What is seen there?
Aneurysm. Leaking.
Okay. Aneurysm and?
Late stages. Blocked fluorescence. It's also seen.
Okay. Fine. Very good. So how will you treat this case?
Laser to the specific aneurysm.
Okay. Anything else? So we need to do any other investigation? See, where is the blood coming up to? It's coming up to fovea, no?
Yes.
OCT.
Yes, OCT. So what are the other things you can get in this case kind of RAM? No, in this case we are getting only hemorrhage. We have got only hemorrhage. So what are the other complications? So you can get macular edema, macular detachment, exudation. So for that, again we have to combine with laser along with anti-VEGFs or even steroids can be used in this case when you have severe exudation with macular edema. Okay, so we'll go to the next case. So what is this picture showing? What is the investigation here?
Intraocular foreign.
Okay, what is the picture above? What is the picture below?
B scan.
AM,
and
A scan,
B scan and A scan.
A scan.
Yes. Okay, what is B scan showing?
Hypertensive focus with back shadowing.
Very good, very good. Fine. So we can see that, say, at the intraocular foreign body, there's an increased reflectivity in the A scan. Yeah, your shouting is seen. Very good. So what are the complications in IOFB?
Endophthalmitis.
Very good.
Depending on the material of the intraocular foreign body,
Very good, super.
chalcosis or siderosis.
Very good, very good. So what is the prognosis in siderosis or chalcosis? Is it good or moderate or poor?
Poor.
Why?
Advanced stage only it is possible.
Yes, very good. So advanced is what happens? Why it is poor?
Fiber layer, fiber.
Okay. So it will cause widespread retinal degeneration. So this photoreceptor loss as well. So the visual prognosis is poor. So you are right. So depending on the material, so whether if it is inert material, what are the inert material like which will not cause any problem even if it is inside the eye?
Glass piece.
Yes. Any other metal?
Gold.
Gold. Super. Very good. Any other metal?
Platinum.
Platinum. Okay. Platinum, I don't know. I have not heard about platinum going to the eye. I have heard gold going to the eye. Platinum, okay, fine. Anything else?
Diamond.
Diamond. Oh, fine. Okay. Diamond. The newer things I'm learning from PGs today. So platinum and diamond, I've not heard anywhere. So you are telling like, okay, fine. So what about wood? Wood will it cause any problem?
Yes, sir.
Okay, if it is contaminated, it will cause problem.
Okay, sir.
Otherwise, so even this pencil lead, no graphite. So when that will not cause any problem. Metal like aluminum also, it will be inert only. Aluminum will be inert, and lead also lead also depending upon the amount of lead material, it can show activity or it can be inert also. So yeah, gold, glass material, maybe okay, diamond and platinum, all those aluminum. So these are all inert. Fine. So also the prognosis depends upon the other associated injuries. We can have a perforating trauma or a penetrating trauma along with endophthalmitis or retinal detachment, vitreous hemorrhage, and penetrating trauma and a perforating and also exit wound. So there will be more damage. So in those cases, we will have poor prognosis. Fine. So we'll go to the next slide. So again, very simple. 52-year-old male patient presented with complaints of blurry vision, blurring of vision of 7 months duration. What is the diagnosis?
Choroidal melanoma.
Okay. So what will you see the clinical features like clinical features as well as you have to tell in the ultrasound features.
Mushroom shape.
Super. Very good. Nice. Good. Anything else?
Clinically, you see a subretinal mass with an overlying retinal detachment.
It is seen here. RD is seen here. This is RD.
Yes.
There's a detachment here. Acoustic hollowing, choroidal excavation, and you can see this here. This reflectivity on the A scan. So what is that?
Angle kappa.
M spike.
Yes. Very good. Very good. Spikes as well. So everybody knows that. Okay. So what are the treatment options in this in melanoma? How will you treat melanoma? What are the various treatment options? Okay, so I'll simplify it also. For small tumors, what will you do? For medium-sized tumor, what will you do? For large tumors, what will you do?
A TTT.
Yes, very good. Next, for medium.
External beam radiotherapy.
Okay.
EBR.
Yeah, EBR. Anything else?
Brachytherapy.
Yes. Very good. Very good. Plaque brachytherapy. And for large tumors?
Enucleation.
Enucleation.
Yeah, very good. Because the fourth question is that because large tumors have high chance of metastasis. So what are the what are the organs where it will metastasis?
Bone.
Liver. Brain.
Most important.
Bronchus, breast,
Liver.
Yeah. So lungs first you have done lungs, liver, and skin. So then it can go anywhere in the body. So these are the first important things. So what is the prognosis in metastasis? Is it treatable? So the prognosis is very poor. So this tumor, when it's outside the eye, is metastasizing in the other parts of the body, the prognosis is very poor. So that is the reason we have to identify this tumor in the early stage itself. And even if you find it in the late stage, we have to do a enucleation. And sometimes if it is orbital involvement, we have to do an eccentric. Okay, so it's very poor prognosis. Fine, we'll go to the next. 53-year-old male patient presented with defective vision in left eye of 3 months duration, no history of any systemic problems. So what is the lesion seen here? Describe the lesion and what is the diagnosis?
This
No, not polypide.
Yeah.
Okay, so just first describe the lesion, you will kind of identify the diagnosis. So what is seen here? What is seen here? What is seen here? You can just tell that, then you can easily diagnose it.
Yeah.
PD.
No PED is seen here. So we can see below the OCT also.
Retinal angiomatous.
No. I have put the OCT also below. There are no PED seen there. See. Anybody able to guess? So I'll give you another clue.
IJFT.
Very good, very good. IJT. Who is that? Who has answered that? I didn't get the name.
Sir, Aparna.
Very good, Aparna. Very nice. Actually, yeah, you identified it. So this is actually, I'll show you the pointer. So see the pigments. Okay, this whitening and this deepening of the vessels. So this is macular telangiectasia. Recently it is renamed as macular. It's easier, macular telangiectasia. So before we were having several names: parafoveal telangiectasia, idiopathic juxtafoveal telangiectasia. So now it is simplified as macular telangiectasia. So what are the necessary investigations? And I already told it here. It's seen here. OCT is very important, and then we have to do as well OCTA as well as FFA. So that I only answered it. Okay, what is the treatment? Do we have to treat this case?
If there is CNVM, we can give anti-VEGF. Otherwise, we can observe.
Okay, here the CNVM is there or not?
Yes, sir.
Yes.
Yes, very good. It is not CNVM, it is SRNV, subretinal neovascularization. So what we are seeing here, this actually the pigment, but what the clue here is, so there will be no macular edema as such, but there will be actually thinning and degenerative changes here. As well, you can see a fluid here. Okay, so in this case, we have to do OCTA or FFA to identify the new vessel and then treat with what?
Anti-VEGF.
Anti-VEGF.
What is the prognosis? The good prognosis as compared with ARMD or bad prognosis?
Don't know, sir.
Okay, so actually from the CNVM, from the SRNVM point of view, it is good prognosis. But if already the vision is poor because of macular telangiectasia, so it is a neurovascular degeneration. So neuronal and vascular degeneration. So already vision is poor because of the IJ mactal, then visual prognosis will be poor. But from the treatment point of view, it needs lesser treatment as compared with ARMD or other CNVM. So it needs really lesser number of injections. So from that point of view, it is having a good prognosis. If the vision is already good, so they will have better prognosis. Okay, very simple. 70-year-old female patient came for annual eye examination. What are the lesions seen here?
Multiple drusen in the post
Multiple drusen.
and pigmentation.
Yes, very good. What is the investigation you will do?
OCT.
Yes, very good. We have to do first OCT. Okay, so do you need to treat this case? So what is the stage of the, so you are diagnosed as drusen, RP changes. So what is the stage of this disease? What is the name you will give?
Advanced.
No, it's okay. It's not advanced. It is intermediate AMD. So how will you treat this patient of intermediate AMD?
We can give antioxidants.
AREDS regimen.
Okay, so we will discuss about that later. So we have some FAQ questions. So you can tell me the formula of AREDS. Very good. AREDS you have to give. Okay, so how do you follow up this patient? Because they have a chance of what? Developing what?
CNVM.
Yes. So how do you follow up this patient? What will you give to this patient to monitor?
Amsler's grade.
Yes, very good. Nice. So depending on the severity, after doing the OCT, okay, so I'm seeing like the involvement of the retina, like how much involvement is there, meaning like PEDs, drusenide PEDs. So we need to follow up these patients maybe 3 to 6 months once, depending on the severity. So early AMD we can even do 1 year once. Intermediate AMD, a little advanced, then we need to follow up closely. Otherwise, we need to follow up every 6 months once, along with the antioxidants. Fine. Okay, so what is this investigation and what are we seeing?
ICG.
Yes. So what are we seeing here in the ICG?
Polyps.
Very good. Who is that? Who has answered that?
Shebiba.
Okay, good. Very good. So these are the polyps. So what else is seen? No, the pictures are a little smaller, but still you can try to see both the pictures and then answer them.
BVN.
Very good. So we can see the BVN here. BVN is seen. And this is actually a feeder vessel. And we can see here a draining vessel. Now it is very, I mean, we have to have zoomed it and then we could have seen. But anyway, these are the lesions seen here. So, okay, where and all ICG is indicated? First, you know, polyps, you already told me. Anywhere else ICG is indicated?
Occult CNVM.
Okay, very good.
CSR.
Very good.
Whiteout syndromes.
Very good. Super. So satisfied. Yeah, it's very nice. All the questions are answered very well. Super. So here we can see this PEDs as well. No? So those are correlating with this polyps. You can see here. So we are seeing this fibrovascular PED that correlating with the polyps. Okay, what is this? What is this investigation?
Octa.
Very good. Very good. Nice. So what are we seeing here?
Feeder vessel.
Yeah.
New vessels.
Yes, very good. Actually, this is a case of PCB only. These are the polyps. Here one. So we are seeing the branching vascular network. Okay. So here we can see this is called double layer sign, where we are seeing a just elevation of the RPE from the Brooks membrane. Actually, there is a material there, like it's not like empty. So through that, I have made this scan. Actually, I have gone through this. I have done a manual segmentation, gone through it, and found out this vascular network. Very good. Okay, so see this case. This is called the double layer sign. Double layer or flat irregular PE. So they can see the fluid here, foveal thinning, cystoid spaces, pachychoroid disease, dilated Haller's vessels. So this is a case of PCB, where we can even identify the polyps even without doing ICG. So I'm doing a study comparing ICG along with OCTA in detection of polyps in PCB. actually, when I saw this picture, no, when I zoomed through the picture, it's a polyp. What we are seeing here, no, actually again it is a network of vessels. There is one publication where says like it is a network of vessels. Because of the flow of the blood there, we are able to see it like a polypoidal, aneurysmal polypoidal dilatation. But it is not a single polyp actually. It is actually a network of vessels. But we are picking it up like that. Okay, that is advanced part for you. For your level, you can call it still polyp only. Fine. Okay. So what are we seeing here? It is very simple. Same. I already told Akta what is
branching vascular.
Yeah, this is actually a case of ARMD. So I was treating repeatedly, but then patient suddenly didn't come because of the lockdown. So I want to know the activity. So we already know that the fluid is still there, but the fluid was decreased compared to the previous visit. So then I wanted to know the activity, whether how much the vessels are there, how much of the caliber of the vessels. So I did an OCTA. So we know that it is still active. We are seeing a large area of neovascular network. So this patient definitely needs treatment. That's what, because patient was telling I am seeing better. Why are you RPC injection? Then I showed this I took it yesterday only. So I just put this, did the OCTA, showed to the patient. See this network. You definitely need treatment for a few more months to cause the regression. Fine. Okay. So what is the diagnosis?
Best disease.
Very good. What are the stages of Best disease? Anyone knows the stages? How many stages?
Pre-vitelliform, vitelli-eruptive, atrophic and CNVM.
Before vitelli-eruptive.
Pseudo-hypopyon.
Very good. Fine. What is the most important investigation?
OCT.
EOG.
Very good. Okay, so somebody can describe that next. Yeah. So what is seen here? What is normal EOG? What is seen in this disease?
Ardence ratio.
Yes. What is the
Light
normal
pink is reduced. 1.8.
Very good. So here it is. We are seeing 1.18 in the right eye and 1.17 in the left eye. So it is confirmatory of Best disease, right?
Yes.
Okay. So what will you do in CNVM stage? And what is the prognosis?
Anti-VEGF.
And what is the
Poor
prognosis?
prognosis.
No. Prognosis is see, for whatever you have to compare with ARMD. So compared to that, prognosis is good actually. So if you find out in the early stage, prognosis is good. If you find out in later stage, because you will get first of all confused whether it is only the Best lesion of Best disease or it is the CNVM. Once we have identified the CNVM early stage, then the prognosis is good. But most of the patients come in the late stage. So in those cases, prognosis is bad. Fine. Okay, so another interesting case. What is the finding and what it suggests? I'll show the finding also.
Hydroxychloroquine.
Very good.
Flying saucer.
So what is it called? What is the sign called?
Flying saucer
Flying
sign.
saucer.
Super, very good. Who has answered that? Flying saucer? Okay, very good. Whoever's answer is very good. Okay, so how will you screen these patients? What are the other investigations you will do? How will you screen this patient?
Visual field examination.
Yes.
Fluorescence.
ERG.
Yes.
Autofluorescence.
Yes. Very good. So actually, first we have to do is first we have to know the criteria, like where we'll do this actually. So first, those who are using for more than 5 years. Okay, 5 years, more than 5 years using hydroxychloroquine or chloroquine. So more than 5 milligram per kilogram body weight of hydroxychloroquine and more than 2.3 milligram per kilogram body weight of chloroquine. So if they're using more than for 5 years, you have to screen those patients. and those who are having renal problems and liver problems, and in obese individuals, we have to screen little earlier because they will have more toxicity in those patients. So we'll see now. The most sensitive test is multifocal ERG, and this is a normal multifocal ERG we are seeing here. And here, actually, in this case, what we're seeing here is, can anybody explain here? Compared to, so you can see, compare it to the normal multifocal and see what is the finding in this affected eye. What are you seeing here?
Decreased amplitude in the central areas.
Yes, very good. So amplitude. So it is measuring each an individual area in the central part of the retina. So those amplitudes in the foveal and the perifoveal area are decreased or either absent. So that indicates the damage to the perifoveal area. I mean, perifoveal and foveal area. So that means there is more damage. So it is the, even we can identify just by seeing the perifoveal area, even a mild decrease compared to the other areas. So we can easily identify this hydroxychloroquine toxicity. Okay. So somebody has to describe this case. Now it is your. So you are going to do more case discussion. So describe the fundus. So somebody who has not answered until now can answer. The PG who has not answered at all. Yeah, others. So the 4 or 5 are answering repeatedly. So anybody who has not answered can describe this case. So very simple. There is nothing like you have to describe the fundus. That's all. Who is volunteering? Okay, so those who are answering also can answer. No problem. Yeah. So others are not answering. So please describe the fundus. Okay, Aparna. Your name is Sinwell. So Aparna. Can you describe? Yes.
Sir, there is macular, submacular detachment.
No. First, describe the fundus. There is a way of describing the fundus. So
Media clear.
Yes.
Disc margins distinct. Size, color, shape normal.
Yes.
CD ratios 0.5.
Okay.
And sir, AV ratios 2:3. And
yeah. Complete.
Okay, so there is submacular SRF subretinal fluid in the macular area.
Okay. What about the other areas?
Appears normal, sir.
Okay, so you have to describe the lesion. So you are telling that. So what is the area? How many disc areas, or how many are the disc diameter? And then any other lesion is seen or not. So you have to describe like that. So you have to describe this area of serous macular detachment, of how much disc areas or disc diameter that you have to mention.
Sir, about 3 disc diameter area, about less than 1 disc diameter area from the.
No. See, diameter and area are different. You have to either use diameter or area.
Oh, okay, sir. 3.
Okay, so you either you tell horizontally how much, vertically how much.
Horizontal, it is almost circular, sir.
No, it's not circular. No, you just describe that. No problem. You are right. So just describe the. Okay, so you can say horizontally maybe you are around 3 disc diameter and vertically around 0.5 disc diameter. Something like that you have to tell, or you have to tell the disc areas. Okay, so what is the disc diameter?
1.5 millimeter.
Okay, so now you have to come to the diagnosis. These findings are suggestive of. So what is the diagnosis?
So CSR.
Very good. So what are the investigations you will do in this case?
Sir, OCT,
Very good.
then FFA
Very
and
good.
ICGA.
Okay. ICJ will do in this case also. Okay, fine, good. Okay, so now I'll just see. We'll see the investigations. So now we are seeing here the color fundus. This is a white field. Clarus photographs. There's a camera name is Clarus. It's a very clear picture. So what is seen here? The FFA.
Leakage point.
What is a leak?
Leak
What kind of leak?
in block.
So we are seeing two areas. You see, there is one leak here, and there is another area of hyperfluorescence. Correlate it with the OCT and then tell me. So I have put all the investigations. Yes. So this is PED, and from the edge of the PED, we are having a smokestack leak. It is not ink blot. It is smokestack leak, and we can see in the autofluorescence as well. There is a ring-like thing. First, there is hypo with a ring outside. That is indicating PED, and we are seeing a leakage here. It's a smokestack leak. So this patient, this leak is there. Where is the leak? So you have to describe like where is the leak. So leak is within FAZ or outside FAZ. Leak is within the FAZ or outside FAZ.
Within
the
FAZ.
Yes. So it is not. Yeah. So it is coming in the subfoveal. Very good. So what is the treatment? How will you treat a CSR case?
Acute cases we can observe. And
if there is leak, we have to give focal laser.
Okay, very good.
Chronic cases we can go for PEDT.
But what kind of laser will be given in this case? So it is in the FAZ. No, so conventional green laser can be given here.
Micropulse
laser.
Okay, very good, very good. So I will just cover it briefly on treatment of CSCR. So first is we have to identify the risk factors. So what are the risk factors?
Pregnancy, corticosteroid intake.
Okay, first
Aggression,
type A personality.
What is type A personality?
Having
perfectionist.
Okay, fine. So first thing is we have to identify all the risk factors. There are several risk factors like sleep disorders, lack of sleep, a lot of stress, type A personality, smoking, alcohol consumption, corticosteroid intake in any form, then pregnancy, then Cushing's syndrome. Then we also like usage of even this nasal decongestant, oxymetazoline drops, and patients who are on psychiatric treatment, already having depression, taking antidepressants. So these are all various risk factors. Also steroids for other diseases like patients like having multiple sclerosis or rheumatoid arthritis or SLE, those who are on also post-renal transplant, any organ transplant, needing long-term steroid therapy, or even those without steroid therapy also per se, renal transplant per se also can cause because they will have more stress, both stress physically as well as mental stress. So these are all the risk factors. And also even dyspepsia due to Helicobacter pylori and sleep apnea. So these are the risk factors which are very important for CSCR. So all these factors, we have to try to remove it or minimize it. Because in renal transplant patients, we cannot completely remove the dosage of steroids. Maybe we can reduce the dosage of steroids. Same with multiple sclerosis or SLE. So we have to try to remove or reduce the risk factors. When there are no risk factors, we can, and patient is not like very usually demanding, so they don't want immediate rehabilitation or recovery, so we can observe in those cases, in acute CSCR. So for extrafoveal leaks, so either the CSR is not resolving even after 3 months, or the patient wants immediate visual recovery, like doctors. So I'm seeing like even a lot of doctors, especially emergency medicine consultants, audiologists, and even surgeons developing CSCR. I have seen even few ophthalmologists developing CSCR. So for them, like conventional green laser for extrafoveal leaks, micropulse yellow laser or photodynamic therapy for subfoveal, juxtafoveal leaks. And also PDT can be used for diffuse leaks. Eplerenone can be given for bilateral cases. Eplerenone is what is eplerenone?
Spironolactone.
Spironolactone is another
potassium
Potassium channel.
potassium sparing diuretic or aldosterone antagonist. So it has been shown recently to be very effective in CSCR. So I use that drug very when in a lot of cases I use this drug eplerenone. So eplerenone for bilateral cases, diffuse or subfoveal or juxtafoveal leaks, especially when they are bilateral. And also I use a combination of eplerenone with micropulse laser if it is not resolving with either one of this. PDT is right now not available in India, so we cannot do PDT for subfoveal or juxtafoveal leaks or even chronic CSCR or bullous CSCR. So we don't have that option right now. So we have to having an option of micropulse along with eplerenone. So we can start with either one and then combine if it is not resolving. So we'll just basically I will tell about photodynamic therapy. The mechanism of action is narrowing of choriocapillaries, choroidal hypoperfusion, and choroidal vascular remodeling. So it is indicated in CSCR when there are multiple leaks, subfoveal or juxtafoveal leak, and the bullous variant of the CSCR. So what is a conventional PDT with normal dosage and fluence? So 6 milligram per meter square infusion of vertiporfin administered for 10 minutes, followed by delivery of laser at 689 nanometers, 15 minutes after the commencement of infusion. The settings is 50 joules per centimeter square for 83 seconds. So safety enhanced. So that is the conventional PDT. But in CSCR, so we are more preferable is safety enhanced PDT. There are two ways. One is low dose, lowering the dose. That is reduced vertiporfin dosage. So instead of 6 milligram, we are using 3 milligram meter square with 10 minutes of infusion, followed by delivery of 689 nanometer laser with 50 joules. Same thing with safety enhanced PDT with reduced laser fluence, whereas the dosage will be 6 milligram, but the joules will be 25 joules per centimeter square. That is called as half fluence PDT. So we have half dose PDT. So the preferred treatment modality is half fluence PDT in CSCR. But since it is not available with us now, so we are treating either with micropulse laser or eplerenone. Okay, so I want another PG to volunteer for the case discussion 2. So describe the funders? I'll just check whom can I call now. So Ashwati, can you tell the case?
Yes, sir.
Yes.
Normal size.
So first start from the media.
Media is slightly hazy.
Okay.
Then normal size with well-defined disc margins. With mild temporal pallor of the disc.
Okay.
And vessels are raised centrally, but there is attenuation of the arteries and veins.
Okay. Yeah, you are right. Okay.
Pigmentations in the mid-peripheral area.
Okay. What kind of pigmentation? So what is called what it is called as?
Pigmentation.
Bony.
Yes, bony spicules.
Bony spicule pigmentation in the mid-peripheral area.
Okay.
RP, retinitis pigmentosa.
Okay. What about the macula?
Macular, foveal reflex is there.
Foveal is absent. Okay, fine. So you should not tell dull. So either you should tell present or absent.
Okay.
Okay, so it is absent now. So what else is seen there? Anything?
Yes.
So at least in the right eye you can see a little better. You can tell from there.
ERM.
I will show the pointer here. So what is seen here? So it is, first of all, FR is absent. So you are seeing some RPE depigmented changes. See here. You can seeing some perifoveal RPE depigmentation. Okay. So diagnosis is RP. So what are the investigations you will do in this case?
ERG.
Fulfilled ERG.
Okay.
Then field test.
Yes.
Target optometry.
Okay. So what about the macula? What test you will do?
OCT.
What are the findings? What are the maculopathies you can get in?
ERM.
Yes.
Cystoid macular edema.
Yes.
Macular thinning.
Okay. So atrophic maculopathy, cellophane maculopathy, and cystoid maculopathy. Okay. So what is the treatment for cystoid maculopathy or cystoid macular edema in CSCR? In RP. Cystoid macular edema in RP, retinitis pigmentosa. How will you treat?
Acetazolamide.
Yes. Yes. Topically, what we can give?
Topical carbonic anhydrase inhibitors like dorzolamide.
Yes. Very good. Very good. Okay. So depending on the stage of RP, the waveforms will be reduced. So when you are seeing in advanced RP, like in this case, it will be completely flat. What will be flat? Responses both dark adapted as well as light adapted will be flat. But in early RP, so you still have cones will be preserved. But when it goes like intermediate stage, at the late stage, even rods or cones will be completely gone. So early RP, like still rod function, cone function will be more preserved than the rods. So rods will have more decrease. The intermediate RP you can see here, still you have cone activity, but in the rods, like it will be completely flat. So it is like rods are more affected than cones. So it is coming under rod cone dystrophy. Like in case of cone dystrophy, so you'll be seeing like cone be completely absent. So here you'll have like you see the bullseye maculopathy along with this full flattening of the photopic response. But you will have still some scotopic response in cone dystrophy. So RP is coming under rod cone dystrophy. Okay. So let us go to the now this is like a kind of rapid fire. All the PG should participate. Anyone can answer. So we'll go to the FAQs. What is diabetic retinopathy? Very simple. So it's fast. Like you have to answer it fast.
Microangiopathy.
Yes, very good. What are the stages of diabetic retinopathy or grading of diabetic retinopathy? So it's all simple questions. Anybody can answer.
Mild, moderate, severe, non.
Okay, very good.
Retinopathy.
Yes. So what are the risk factors?
Long-standing diabetes.
Associated hypertension, dyslipidemia, renal disease, anemia, hyperlipidemia.
Super, very good. All are covered. So what are the investigations you will do in diabetic retinopathy?
OCT macula.
Okay.
OCT FFA.
Angiography.
Okay. So when FFA is indicated?
Throughout the NVE.
Okay. When OCT is indicated? So we'll do OCT in every case of the DR.
No, in severe NPD, look for any early to diagnose early PDR changes.
That is FFA. OCT when you are want to rule out macular edema. Okay. So what is the treatment for PDR?
Anatomy photocoagulation.
PRP.
Okay. How will you do PRP? How many sittings? What is the laser you use? What is the laser? What is the laser we use? What is the wavelength of the laser?
532.
India.
YAG laser. 532.
Okay. Yeah. If frequency double YAG laser, 532 nanometers is coming in the green laser. So that we will do. Okay. What is the treatment for CSME?
Anti-VEGF, intraocular anti-VEGF.
So when we are having extrafoveal, yeah, we'll give laser. Still grid laser or focal laser is still indicated in extrafoveal CSCR. That is non-central involving diabetic macular edema. We still give focal or grid laser. Only when it is central involving edema, we are planning when we give anti-VEGFs. Okay, very good. So this already asked question. How will you follow up a case of PDR post laser?
2 months.
Yes, very good. What are the indications of vitrectomy?
Persistent weakness and
Yes.
fractional detachment threatening the macula.
Yes.
Combined.
Combined, Daddy.
Yes. Combined mechanism. Yes. Yes.
Vitreomacular traction.
Okay. Yeah. Vitreomacular traction also is very important indication in macular edema. So, what are the complications of vitrectomy?
Chances of anterior segment neovascular.
Yes. Yes. Correct.
Cataract.
Yes. So when you're doing for vitreous hemorrhage, so you can also have after clearing also what you can get.
Iatrogenic holes and
RD.
Okay, so you have to classify this as immediate post-op complication, late post-op complication. So you can also have this deep bleeding, okay, in RD, recommended as RD, or tractional detachment, like it's try to attach, but still this remnants can still grow and there can be again re-RD, both recommended as well as in tractional retinal also you can get again worsening of RD until if you are not put oil, no, you just put gas, that again possibility is there. Okay. How will you treat a case of NVG due to PDR?
Anti-VEGF along with the aggressive PR.
Yes. Okay.
Then management of glaucoma part.
Yeah. Okay. So what is DRS?
Diabetic retinopathy study.
Okay. What is the
Is there any role of?
Is there any role for photocoagulation in diabetic?
Photocoagulation in diabetic.
Okay. So what is the result?
PRP reduces the risk of severe vision loss to 20 to 50%.
Very good. Very good. Who has that? Who has answered the question? Okay. Fine. Okay. What is ETDRS?
Early treatment diabetic retinopathy study.
Okay. What is the result of this? Like, what is the conclusion we have got from the study? Conclusion of ET. So conclusion of DRS, very good. You have told. What is the conclusion ETDRS? Yes.
Photocoagulation is indicated.
Yes.
Focal or grid laser photocoagulation for macular edema.
Okay. So it reduces the visual loss by 50%. It reduces. Okay. And PRP was beneficial only in PDR, not before that. Okay. High risk PDR than this. And what is DRVS?
Diabetic retinopathy vitrectomy study.
So what are the results for DRVS?
severe vitreous hemorrhage early.
Yes. Okay. So early vitrectomy, not every case of in severe vitreous hemorrhage needs.
Type 1.
Yes. Very good. Very good. Type 1 patients need early vitrectomy because they will have this severe bleeding as well as rebleeding also is very severe because of the ischemia is more in those cases. Very good. Super. So you have covered all these studies. We'll go to the next topic. RMD, what is drusen? This is a simple question. What is drusen? Very easy.
Hyaline deposits in the Bruch membrane.
Very good. Underneath the RPE, between RPE and the Bruch membrane. Classify ARMD.
Dry and wet ARMD.
Okay. What are the features of dry ARMD?
Drusens and pigmentation, which can be classified into early, intermediate, and late.
Okay. What is the late?
The Large drusen's more than 125 micrometer along with pigmentation.
Okay. What are the features of wet ARMD?
CNVM.
Drusen.
Okay, so drusen's, pigmentary changes, CNVM. So what you will see in CNVM? Like you cannot pick up CNVM directly, no? What is it?
Hemorrhage, exudates.
Yes. Detachment, edema. So whenever you suspect all this, there is activity of CNVM. So what are the investigations you will do in a case of ARMD?
OCT.
Yes.
OCT angio.
Okay.
Okay.
Okay. So people are like using OCTA also. Very good. What is geographic atrophy?
In stage of dry AMD.
Okay. How do you define geographic atrophy? So what will be seen in geographic atrophy?
RP will be atrophic.
Okay. So what will be seen underneath? The choroidal vessels will be exposed.
Okay, sir.
Okay. So it's a severe RP atrophy where you can see the choroidal vessels getting exposed. So ARMD is one of the causes of geographic atrophy. You can have non-AMD geographic atrophy also, like severe myopic maculopathy also. Okay, so So favorite question, AREDS 1 and AREDS 2 formula. Anybody can answer what is AREDS 1, what is AREDS 2? Difference between 1 and 2. A simple question. Anybody can answer.
Antioxidants are given for.
No. I am asking the components of AREDS 1.
Okay. Beta carotene.
Okay.
Zinc, copper, vitamin E, vitamin C.
Okay. 2 formula.
Beta carotene is avoided and they added
Zeaxanthin and lutein.
Okay, fine. Why beta carotene was removed?
Risk of lung carcinoma.
Yes. Okay, fine. What are the differential diagnoses of ARMD?
Doyne's honeycomb dystrophy for dry ARMD. Doyne's honeycomb dystrophy.
Okay.
Then familial dominant drusen.
Both are same. Doyne's honeycomb dystrophy and familial dominant drusen are same. Okay. So
cuticular drusen.
Okay. Okay, so any case is again, if you consider PCV as a separate disease, so PCV will be DD. CSCR with CNVM will be DD. So any cause of CNVM will be DD for ARMD because you can have drusens along with other cause of CNVM. So that has to be ruled out because of presence of drusen. No, you have CNVM from any other etiology, you'll have a confusion of ARMD. So that has to be kept in mind. So your first, the first two things you told are very good. The familial dominant drusen along with CNVM, definitely. The age group is less than more than 50, you will definitely have a diagnosis out of ARMD. Very good. How wet ARMD is treated? Yes?
Anti-VEGF.
Only anti-VEGFs I'm asking. What are the anti-VEGFs you know?
Ranibizumab.
Aflibercept, brodizumab.
Okay. What is the we already answered it. What is the recently approved anti-VEGF?
Brolucizumab.
What are the risk factors? Like what are the adverse effects? What are along with brolucizumab or Pagenax?
Vasculitis.
Very good, super. What is the trial?
Hawk and Harrer trial.
Very good, super.
Hawk and Harrer.
So yeah, people are very well informed. So this is the hottest topic now, and I have been giving talks on Pagenax, that is brolucizumab. I started using recently for PCV cases, and I'm getting very good results. But very less. I have not seen any adverse effect. And many of my colleagues throughout India also are using it. Only one case got severe on vascular occlusion actually. So mostly it is safe only, but this trials like still we have to be very careful. So we don't use it in overnight patient or treatment naive patient. So we have to decide cases, explain the side effects, adverse effects, and then take the proper cases. So if you cannot take a case with very good care, it's very good vision like 6/9 and then inject map. But treatment failure cases, even with Eylea treatment failure cases or ranibizumab treatment failure cases, there we can try whether the other eye is having good vision. We have to clearly explain and then try this. So I have been started using this drug like recently for past few months, and I'm getting good results. Okay, what is Marina trial?
Ranibizumab.
For what?
For minimally classic CNVM.
Very good, very good. Yeah. What is Anchor trial? Anchor trial compared.
Predominantly classic CNVM.
Yes. Okay. So what is better there? Which is?
Ranibizumab is better than.
Yeah, very good. So Anchor trial compared ranibizumab with PDT. Okay. What is CAT trial?
Compared various anti-VEGFs.
Yes. So what is the conclusion of CAT trial? This is very important. CAT trial is very important. So compared what? Compared what? With injection with injection.
Ranibizumab, bevacizumab.
Okay. So what is the conclusion? Very simple, no? Conclusion is very easy. The efficacy of both are same. However, there was more adverse effects reported with bevacizumab, thromboembolic events, as well as anti-VEGF associated adverse effects were reported. But efficacy-wise, both are same. This is very important because bevacizumab is an unapproved drug. We are using it off-label. So we are using it off-label. So that has to be mentioned in the consent form when you are injecting bevacizumab. So throughout the world, that is the most commonly used drug for ARMD. But still, it is not approved by any regulatory body. Is Avastin approved in Kerala? Kerala state, is it approved? Avastin for any treatment for retinal diseases?
No, actually not yet.
Okay. So that's the reason I'm telling, because it's not FDA approved. It's not. Kerala is not approved, but Tamil Nadu is approved. We are using it. So that is the commonest drug we are injecting. So efficacy-wise, it is similar to ranibizumab, but in treatment-resistant cases, definitely ranibizumab will be better. Anybody knows? Any PG knows Rajumab? What is Rajumab?
It is a biosimilar drug.
Of ranibizumab.
Okay. What is biosimilar?
It is chemical composition same, but the processing, manufacturing technique.
Okay. Super. Very good. Very good. So the last topic will come like retinal detachment. So what is retinal detachment?
It is a separation of neurosensory retina from the RP.
Okay. What are the types of RP?
Pragmatogenous, exudative, and fractional addict.
Define retinal tear.
It is a break in the neurosensory retina.
Okay. Full thickness.
Okay, sir.
Full thickness. Yeah. Tear in the break in the neurosensory retina. What is retinoschisis?
It is a separation.
Yeah, within the layers of retina. Okay. What is retinal dialysis?
Disinsertion of the retina from the ora serrata.
Okay. What is GRT?
Tear involving more than 90 degree, means more than one quadrant.
Okay. More than 3 clock hours or 1 quadrant. What are the peripheral retinal degenerations predisposing to RRD?
Lattice degeneration, snail track degeneration.
Yes. Any other thing? In lattice.
White with pressure.
Yes. In lattice, every lattice is same, or you have like classification of that? See, now routinely when myopes will be sent to retina clinic for when when before they are like taken up for LASIK surgery, patients with myopia, high myopia, will be referred to the retina clinic. So we see quite a lot of lattice in every case. We don't barrage every case. So pigmented lattice
with the hole.
break.
Yes, lattice with atrophic fold, lattice with severe thinning, pigmented lattice, and if the patient is having symptoms, what symptoms like floaters or flashes, those only we take. So not every lattice we treat. So lattice can be there in even normal, not even in sometimes even in hypermetropia, hypermetropia we can see, or eumetropia also we can see. So we have to treat only those who are for having problems, additional problems. Okay. So how it is treated, how the peripheral retinal degenerations are treated or breaks are treated. What are the two ways we can treat?
Barrage laser.
Okay. Then anything else we can have?
Anterior.
Yes. Okay. Good. Cryotherapy or cryopexy along with or barrage laser. Okay. So how do you do barrage laser?
2 to 3 rows of confluent laser burns are applied around the break.
What degree of burns?
Moderate intensity.
No. Moderate we don't give in. We give only like more than moderate burn, like not lesser than moderate, more than moderate. So this white burns you have to use. Depends actually. So depending on the amount of detachment as well as the amount of traction. So depending on that you have to do. Okay, maybe smaller, just the atrophic folds we can give moderate burns, but if it is severe, we can give heavy burns also. Okay, so what is the treatment of RRD? This we have already discussed in the third case, but anyway, what is the treatment for RRD?
Yes. Pneumatic retinopexy, buckling, vitrectomy.
Yes, buckle and unbuckling and vitrectomy. Okay, when vitrectomy is indicated in RRD?
Associated with PVR.
Yes.
Giant retinal tear.
PVR grade
C.
Okay, C2, yeah, at least 2 clock. Okay, fine. Yeah, GRT. Then dialysis.
Post. Standing VS.
Yes.
AC media.
Okay. Fine. What are the tamponading agents used in vitrectomy?
SF6 and C3F8.
Okay, very good. And another thing, gases are like that, then
Silicon oil.
Okay, so once you have injected silicon oil, after how many days you have to remove the silicon oil?
6 months.
Yes. Okay. What are the complications of having silicon oil for a long time?
Secondary glaucoma.
Yes, because
anterior migration,
emulsification of
migration and anterior migration.
Okay. What is the one like anterior segment? What you will see like in long-standing
inverse
hyperpan.
What it is called?
Inverse hypertension.
Very good. What it is called as another name is? Yes. Very good. Very good. Okay. What are the steps of vitrectomy? What is PPV?
Pars plana vitrectomy.
Okay. So what are the steps of PPV?
First, we have to make the pot with the 25 or 27 gauge needle. Then
Very
core
good.
vitrectomy.
Yes.
Then after that, base excision, and then fluid air exchange with the laser applied around the retinal break. And along with SR.
No, one thing you have left. I mean, important thing.
PVD induction.
Yes. Very good. So PVD induction, and then like PFCL can be used, or you can use air only for the fluid drainage, and then correct, laser, and finally like we have to put the tamponading. Either it can be air or C3F8 or SF6 or silicon oil. So when silicon oil is indicated, when gas can be indicated.
If patient is planning for air travel, we have to use silicon oil.
Yes.
Long tamponade.
Tamponade.
Very good. So more like superior breaks, like if you have iatrogenic superior breaks, then gas also will be fine. But if you are having like inferiorly, like maybe better to go for silicon oil or multiple breaks like iatrogenic or the breaks are already inferior. So those cases, and severe PVR cases, and TRD like extensive TRD involving inferior quadrants. So those cases you have to give better to go for silicon oil, right? Okay. So thank you. So I have tried to cover as much as possible, like in this short time of 2 hours. These are the images that me and my team have sent this as a cover image. And in this year, these 4 have got already published, and another 6 more have got accepted. So for the benefit of PGs, I'll just tell these images also. This in the February month of eye issue, this is the enhanced S1 syndrome. And in the ophthalmology retina of May, it is actually Biatis crystalline dystrophy with coronal neovascular membrane. Second case to be reported in the world. This again, somebody has told already. Anybody can diagnose this? This was told already. Just when we were discussing ARMD. Yes.
Cuticular drusen.
No, this is Doyne's honeycomb or familiar dominant drusen with scarred CNVM. And this last case is a case of macular with radial pattern hemorrhage because it is in the Henle's layer. So radial pattern hemorrhage in a case of macular telangiectasia with intraretinal neovascularization with bleeding. So these are some of the cover images like got accepted this year. Thank you. So any other doubt, anything we can discuss.
So postgraduates, if you have any doubt, you can just clarify it now itself.
But I actually like most of like at least 4 answered, so they are knowing very well. I'm really like happy to know that they are knowing this much. They are telling even the hack and harrier trail. I think they have read everything, so I'm really happy that PGs are so much interested in retina and they are knowing up to date. Because they may not get an opportunity to use it, but I am using it right now. I'm just still learning with brolucizumab, but they are telling about all the adverse effects and how can harrier trail, all those things I'm reading for past 1 year. So very good. I'm really happy. They are very, very well informed. And also most of the questions, 90% of the questions they are able to answer. Maybe they need some more, little more preparation. They can even answer 100%. I'm really happy.
May I request Dr. Dahlia to give the official vote of thanks?
Yes.
We can also thank directly, sir, for his time and efforts he has made.
So good evening all. I think we all agree again a great PG session today. So to make this session so successful, first of all, I would like to thank Dr. VIGNESH TP, our amazing faculty who has given us a very interesting and interactive session in a very simple and lucid manner and very systematic, and also a revision with FAQs at the end. Thank you, sir. Thank you for your effort, and thank you for your time given. Thank you, sir. Also, I would like to thank Dr. Mihir, first of all, for inviting such amazing faculty and also for moderating this session. I would also like to thank our KOS President, Dr. Vijayalakshmi ma'am, and our KOS Secretary, Dr. Sujit, for planning and organizing these sessions for the benefit of our PGs. Also, I would like to thank our PGs who have been very enthusiastic and encouraging us with their full support. Thank you, PGs. I hope it's useful for all of you. And also, lastly, but not the least, I would like to thank our sponsors, the Milmed division of Sun Pharma, for their support. Thank you. Thank you all.
Thanks a lot.
Yeah, thank you, sir.
Dr. Vignesh, superb work. Thanks a lot. And Dr. Mihir, again, once more, thank you to Mihir to bringing in Dr. Vignesh, the PG teaching curriculum.
Yeah.
Vignesh, how are our PGs as compared to the PGs at Arvind? How are they faring?
Yeah, they are equal actually. So I'm really happy that to know that they are knowing so much actually. So every day, like I discuss with my PGs every day. So I like just make fun of them, like you know this, you don't know this. not seriously, as a friend actually, I usually do every day. It is something. But here, like actually, yeah, they are knowing so much. They are knowing actually. I'm really surprised. I don't know like whether these four posted along with me right now will know the Hawk and Hager trail. They may not, maybe. So I'm trying to teach them, but I'm really surprised with this. Actually, and also most of the questions they answered very well. So because here, no, like yeah, we are training them. So like exam oriented training is like only given as sort of final year PGs. So the first and second year PGs may not know like how to tackle this actually ASCII pattern or this yeah. So like this case session, most of the PGs will answer the FAQs and all those things. So like to the point answering, like so they most of the PGs answered to the point. So that was great actually. So last year I went as an examiner. So for a MS batch at Mother Medical College. So that time only I learned how to ask questions actually. So I mean from the official point of view, examiner point of view. So I learned from my seniors there. So most of the retina thing they left to me. So I was supposed to ask them. But then I learned from them like other my seniors like senior examiners who were asking. So how to ask it, like how to ask questions and ASCII patterns. So I was not exposed to ASCII before. So once I became an examiner now, like I'm then going and then asking. So I'm really happy that PGs are very well like informed and knowledgeable. And yeah, we can look forward like for them to join fellowship at Arvind as well. Like whoever is interested in retina are welcome. We need good people who can learn from us as well as after learning like work with us in some projects and make some academic publications as well. So we are actually like giving a lot of importance to publications. So I have started now doing the work actually. So I'm also happy to inform that like my thesis, which I did way back in 2005, got published as an original paper in the journal I. So I was the first PG to have a thesis to be published in an international journal. So now after that, it was a start actually, but after that, several people have done that at Arvind. So like that, we need like all the PGs to be more involved in academics, not only for exam point of view, as well as for publications that we need to give more importance. And also I look forward for this bright PGs to join Arvind, any branch. If they want to work under me, they can come to Madurai as well. So we have a lot of opportunities as well to learn, as well as to grow, as well as we sometimes know like even fellows teach us something like which we may not know, like how to approach certain project like or some other ideas, newer ideas. So it's a lifelong learning process. So being in an academic institute, no, like even I used to tell my PGs and fellows every day something new I am learning, something which I have not seen before, something which I have to work more. So we always feel like we are always humbled by our patients because we don't know sometimes many times we don't know how to deal with the patient or something like they are seeing something new, a combination of 2-3 diseases. So how to deal with those cases? So that is possible in an institute like Arvind because of the volume. So yeah, we are getting tired. That is definitely there, but these things keep us motivated. So that it also humbles us as well as to learn more. So every day, so I still think I'm a student only. So I'm a student of retina, and I want to learn something. I am learning every day something new and trying to help out the patients. Maybe from one patient what I learn, I will try to apply to the next patient. The similar cases. So I'm really happy with the PGs of Kerala.
Yeah. So thank you, postgraduates. I mean, you got the compliments from the master himself.
No, I'm not a master. I'm a student only.
Okay.
Yeah, great going, postgraduates. It's a great compliment from Dr. Vignesh. He has invited you people to the fellowship. What more you do?
Yeah. So these questions will, yeah, a little bit more will pass for the interview. So once you have tackled that, you can join our institute. As we have I already told you 2 programs: medical retina 1-year program, 2 years of surgical retina, and 3 years of retina research and vitreoretinal surgery. So whoever wants to spend longer time in learning retina also are welcome. So we need more talented and interested people, interested to work hard as well as learn and as well as contribute. Yeah. And again, I thank everybody like Dr. Madam, and also KOS to give me this opportunity to interact with the PGs of Kerala. Thank you.
Thank you, Vignesh. Okay. Good night.
Yeah.
Thank you.
Good night.
Thank you.